Hello and welcome to this educational program titled Shared Decision Making and Patient Education to Promote Adherence to Direct Oral Anticoagulants and Continuity of Care in Venous Thromboembolism. My name is Allison Burnett and I'm an antithrombosis stewardship pharmacist at the University of New Mexico Hospital. And this educational program is available for a half hour of CE and CME through an independent educational grant from the Bristol Myers Squibb and Pfizer Alliance. In this educational module, we'll be focusing on the direct oral anticoagulants, which have become the cornerstone of therapy for VTE, or venous thromboembolism, that includes both DVT, deep vein thrombosis, which are blood clots primarily in the legs or arms, and PE, or pulmonary embolism, which can occur if a DVT travels from an extremity through the heart and into the lungs. For more than 70 years, complex therapies such as vitamin K antagonists like warfarin were the only oral medication options for treating VTE. But a little over a decade ago, several randomized controlled trials, including more than 25,000 patients, compared 4 DOACs, dabigatran, rivaroxaban, apixaban, and edoxaban, with these vitamin K antagonists, and the results showed that the DOACs as a class were just as effective and significantly safer in treating acute VTE. Importantly, DOACs are also much more convenient than vitamin K antagonists because they were designed with a high degree of specificity for specific clotting factor targets. Factor 2A, or thrombin, for dabigatran, which is a direct thrombin inhibitor, or factor 10A for apixaban, rivaroxaban, and edoxaban, which are factor 10A inhibitors. And this allows these agents to be given in fixed doses with fewer interactions and no need for monitoring of anticoagulant activity. And this is very different than warfarin, which targets multiple clotting factors throughout the clotting cascade, has numerous drug diet and disease state interactions, and also requires frequent monitoring of anticoagulation activity via the International Normalized Ratio, or INR, to ensure that patients are within a specific therapeutic range. And because of this improved safety and convenience, DOACs are now preferred over warfarin in most VTE patients by evidence-based guidelines. And when we examine prescribing patterns over the last decades, what we see is this rapid decline in warfarin use and increasing use of the DOACs, particularly rivaroxaban and apixaban, that employ a simple single drug approach. And this is unlike the other DOACs, edoxaban and dabigatran, because they require a parenteral 5-day lead-in, and this can be inconvenient, costly, and cumbersome for patients. So in your clinical practice, you will most likely be prescribing and or managing apixaban or rivaroxaban for VTE treatment. Not only are there important differences in safety and convenience between vitamin K antagonists and DOACs, there are also important differences in pharmacokinetics that clinicians must be familiar with. And one of the most important is the medication half-lives, which is associated with the duration of anticoagulant activity. On average, apixaban and rivaroxaban have a drug elimination half-life of about 12 hours. And these relatively short half-lives and short durations of actions mean that adherence is essential, because any missed doses or non-adherence to a DOAC can lead to rapidly decreasing plasma concentrations and subtherapeutic levels of anticoagulant activity, which can increase our patient's risk for a thromboembolic event, such as a DVT or a PE. Now, medication adherence is commonly assessed with a measure called proportion of days covered, or PDC, and this is based on prescription fill data. A PDC of greater than 80% is considered good adherence, and less than 80% is considered poor adherence or non-adherence. Now, in those early randomized controlled trials I mentioned that showed equal efficacy between DOACs and warfarin for VTE treatment, there were very low rates of non-adherence, ranging from just about 4% for patients in the Amplify trial with apixaban and about 7% in the Einstein trials with rivaroxaban. So this means that in both of these trials, there were very high rates of DOAC adherence, and that clearly influenced the efficacy outcomes within that controlled environment. But how does this compare to DOAC adherence and patient outcomes in the real world? Well, a retrospective analysis from the Kaiser Permanente Health System in Colorado suggests that for DOAC adherence, again defined as PDC less than 80%, is higher in clinical practice than in controlled trials. At 6 months, it was nearly 12% and associated with a 10-time increased risk for recurrent VTE. And at 12 months, it was roughly 16% with a 5-fold increase risk of recurrent VTE compared to patients with good DOAC adherence. So DOAC adherence is essential, and it should be a major point of emphasis during initial patient DOAC education and at each longitudinal touch point with patients across the continuum of care. It's important for us as clinicians to have understanding of what drives DOAC non-adherence so we can effectively assess it and address it. There are 2 main types of non-adherence. There's intentional and unintentional. The most common type of unintentional non-adherence is simple forgetfulness. And this can be addressed with patients in a few ways. So for example, they can be encouraged to use reminder aids, such as pill boxes or apps on smartwatches or phones, or they can anchor their medication administration to regular activities like dinner or going to bed. Importantly, there's other types of unintentional non-adherence that we have to routinely assess for, and this includes loss of medication access because of formulary changes, or we often see our Medicare Part D patients falling into that donut hole near the end of the year, and we need to assess and be aware of this. There are also several types of intentional DOAC non-adherence. These have been identified through patient surveys, and they include things like concerns about bleeding or bruising, interferences with lifestyle choices such as alcohol consumption, and very importantly, patient perceptions that medication is not important because it doesn't require monitoring, or perhaps the patient is no longer symptomatic and they think they don't need the medication. So while DOACs are advantageous in that they require less frequent monitoring and fewer follow-up visits, this can actually become, a proverbial double-edged sword because there are fewer opportunities to assess for and address adherence or other DOAC issues that may negatively impact patient outcomes. It's important for us to think about the point that the incidence of VTE is anticipated to at least double by the year 2050 due to secular trends such as obesity and an aging population. Most of these patients will be treated with a DOAC, so it's becoming increasingly evident that we as a healthcare community need to identify strategies to effectively address DOAC non-adherence in VTE patients if we expect to see patient outcomes like those seen in the DOAC VTE clinical trials. Recruiting patients as our partners in VTE care may be a highly effective means to optimize DOAC use, but successfully recruiting patients as our partners is going to require a paradigm shift in our practices away from the clinician as decider approach to more patient-centered strategies, which include high degree engagement through shared decision-making, coupled with comprehensive patient education on both anticoagulant therapies, as well as overall disease state management. And through these key actions of engagement and education, we can then empower our patients and their families and their caregivers to become active members in the care plan and a valuable part of the multidisciplinary team. Successful patient engagement requires a thoughtful and methodical approach where we avoid assumptions, preconceived notions, or trying to use one-size-fits-all strategies. We need to take time to find out what our patients' learning needs are. What do they already know about VTE and blood thinners? What information do they still need? We also need to assess their ability and willingness to learn, as well as what educational modalities are going to be most effective in their education. And most, if not all of this, is related, at least in some way, to health literacy. So it is important that we all have a very good understanding of what exactly health literacy is and how it impacts our patients. These are formal definitions from the Healthy People 2030 initiative out of the Department of Health and Human Services. And these were recently expanded to include not only personal or individual health literacy, but also organizational health literacy, which promotes accountability and transparency for more equitable access to and understanding of health information and resources. Examples of this include providing patient portals in multiple languages, utilizing portal language at an appropriate reading level, and ensuring use of lay terminology in patient-facing documentation within the portal. For this educational session, I'll focus on personal health literacy, which is the degree to which a person can find, understand, and use health information and services to make decisions and take action in their own healthcare. Estimates suggest that overall, only about 12% of adults in the United States have proficient health literacy to adequately navigate the healthcare system and make informed decisions about their care. Health literacy is heavily influenced by social determinants of health, such as older age, race, ethnicity, access to healthcare, education level, along with socioeconomic status. So clearly there are certain groups that are consistently more vulnerable to poor outcomes that are related to low health literacy. And because this is such a ubiquitous issue in healthcare, it is definitely something we need to keep in mind each time we engage with a patient. Low health literacy may not be overtly apparent, or patients may not be forthcoming about their lack of understanding, but there are certain flags we should watch for that may indicate low health literacy, such as missed appointments, difficulty completing forms or reading prescription labels, or one of the more common ones is making excuses when asked to read or discuss written materials, like, oh, I forgot my reading glasses, or I'll read this when I get home. So we need to be on the lookout for those flags. When low health literacy is suspected, either formal or informal or both assessments should be conducted. There are several formal health literacy assessments available online, including the newest vital sign and the health literacy questionnaire. These tools have the advantage of being highly standardized, and that may minimize biases and promote equity, so their use is recommended whenever possible. However, informal assessments can also be extremely informative, and this simply involves taking time to ask your patient open-ended questions related to health literacy. Things like, how do you prefer to receive medical information, or how often do you ask for help reading prescription labels? And then making time to actively listen to and document your patient's responses. One of the most important considerations when we are doing health literacy assessments is to do this in a private setting. Patients with low health literacy might be embarrassed, so it's imperative for us as trusted healthcare providers to respect the patient's dignity and privacy when exploring this with them, and avoid making them feel ashamed or targeted. We also need to distinguish low health literacy from other clinical issues, such as developmental delay or cognitive decline or any type of mental illness. And then we need to make sure we discern English language proficiency from health literacy, because a person who is more proficient in a non-English language doesn't necessarily have low health literacy, but they may very well need education and information in their preferred language. Once you have done a health literacy assessment, you and your patient will be ready to engage in a productive shared decision-making process regarding their VTE treatment. Now, shared decision-making represents a paradigm shift away from paternalistic models of care in which clinicians make therapeutic decisions for the patient. Instead, shared decision-making, or SDM, takes into consideration not just the scientific evidence, but also the patient's values and preferences, along with those social determinants of health that might influence the patient's ability to optimally utilize prescribed VTE therapies and care plans. So SDM provides a very valuable framework to help you engage with your patient and identify the oral anticoagulant option that fits best with things like their lifestyle, their financial situation, transportation status, access to food, etc. And this is all vitally important because the best drug to treat VTE is the one that the patient will be consistently adherent with. You've probably noticed that shared decision-making is increasingly recommended in clinical guidelines. And we're actually starting to see development of formalized decision aids that incorporate numeracy, health literacy consideration, and exploration of social determinants of health to enhance patient understanding and their ability to make informed decisions about their care. There are several resources available for free online, including a very comprehensive shared decision-making toolkit from the Agency for Healthcare Research and Quality, or AHRQ, for any attendees who might be interested in downloading that. Many of the formal tools that have been developed to date are focused on atrial fibrillation, which is the most common indication for anticoagulation. But core tenets of SDM, such as presenting the patient with all of their options and then methodically examining which one will fit best in their life, can be taken from these models and applied to any anticoagulation indication, including VTE. Through a standardized, methodical, shared decision-making approach, patients' values and preferences are prioritized, and this helps to identify and address any potential barriers to adherence and continuity of care. So, for example, if a patient is living on a limited income or does not have prescription benefit coverage, a DOAC may be cost prohibitive and it might not fit within their lifestyle. And this might lead to stress and anxiety about being able to afford the DOAC, or even worse, the patient might end up trying to stretch their medication supply by skipping doses or cutting tablets in half, and we all know that that can lead to poor outcomes. However, if this type of issue is identified early, alternative approaches such as use of warfarin or patient assistance programs can be explored with the patient. Similarly, patient preferences around things like dosing frequency and dietary considerations and monitoring burden for a particular anticoagulant are very important to discuss with a patient prior to prescribing. So, for example, a rivaroxaban maintenance dosing for VTE is just once a day, but it must be taken with food to ensure adequate absorption. Alternatively, apixaban is dosed twice a day, but it doesn't require food intake for absorption. So discussing these medication differences with the patient helps identify the agent that they can most readily access and be longitudinally adherent with. Be aware that patients may place different values on preventing clotting or avoiding bleeding, particularly if they've had prior negative clinical experiences. So another key aspect of shared decision-making is discussing both the potential benefits and the potential harms of a particular anticoagulant. And to ensure patient understanding, we need to avoid using confusing terms such as relative risk reduction or hazard ratios when discussing risk versus benefit. Instead, we should use images like pictographs with easy to understand numeracy whenever possible. And remember, the average reading level in the US is the 5th or 6th grade, so any materials used in shared decision-making have to be written at this level to best support the patient in making those important, informed decisions about their care. So as shared decision-making becomes more integrated into our practices, we will likely see more of these digital platforms emerge for clinical use. But I want to emphasize that clinicians don't have to wait for a fancy digital tool to engage and empower patients in their decision-making. You can start doing this in your practice today by creating a standardized set of questions that take into consideration those key aspects we just discussed, such as anticoagulant cost, dosing route and frequency, dietary considerations, and risk versus benefit to identify the best anticoagulant for a particular patient. And again, anytime we use standardized approaches, such as a standardized set of questions and a systematic approach, this is going to minimize the risk for bias and health inequity. Importantly, shared decision-making sessions need to be conducted regularly, and I would suggest at least once a year, because patients' values and preferences can and do change over time. So once you've identified an anticoagulant regimen that fits best with your patient's values and preferences, you can then begin providing comprehensive patient education on that particular therapy and their overall VTE management. And I'll take opportunity to emphasize that whenever possible, it's recommended to involve family or caregivers in the education process so everyone has a high degree of understanding and can best support the patient. Antithrombosis stewardship is an emerging care model you may have heard about that centers around 7 core elements focused on improved patient care. And these core elements were developed through a partnership between the Food and Drug Administration and the National Nonprofit Anticoagulation Forum. Patient education, comprehension, and competency pertaining to antithrombotic therapies is one of those 7 important core elements. And this core element focuses not only on education of patients, but also education of anyone involved in that patient's care, including multidisciplinary clinicians. For the purposes of this educational model, I'm going to focus on patient, family, and caregiver education. In addition to the core elements for anticoagulation stewardship, the provision of patient education is also supported by major societal guidelines on optimizing anticoagulation therapies, such as those from the American Society of Hematology. In the ASH guidelines and supporting meta-analyses, the authors do acknowledge that optimal approaches to development and delivery of patient education information remains unclear, and this is certainly an area that is ripe for more research. But the prevailing perspective is that patient and caregiver education is essential for high quality anticoagulation management because it improves knowledge on risks and benefits of these high alert yet essential anticoagulant medications. It increases self-management skills, and it promotes adherence and improves outcomes. So patient education should be incorporated as a core element of our practices across the continuum of care. Studies have suggested that about half of the medical information we share with patients during office visits is forgotten almost immediately, and the half that is remembered incorrectly. So this just underscores the importance of not relying on recall alone, but rather having easy to use and understand patient educational tools and approaches that are based on suggested best practices. For example, it is recommended to involve health literacy professionals whenever possible because they can provide valuable expertise for layout and presentation of the content, such as short bulleted sentences, lots of white space, pictures, and large font. And again, these materials have to be written at the 5th or 6th grade level so they can be understood by most patients. Educational resources should be available in multiple languages, and they need to be assessed for cultural appropriateness to ensure a positive patient engagement. And they need to be available in multiple formats to best accommodate the patient's preferred learning style. Now, if materials are not available in the patient's primary or preferred language, very often use of an official interpreter is required. And additional accommodations may need to be considered and explored for any patients with disabilities such as deafness or blindness. When providing patient education, clinicians and trainees should consistently use open-ended questions to elicit the most information from the patient. So instead of asking, does your blood thinner have to be taken with food, which can be answered with just a yes or no, asking it as, how should you take your blood thinner each day, invites a more detailed response. And education approaches should routinely incorporate the process of teach back to assess the patient's understanding of the information at the point of care. And here I would just emphasize, always be patient with your patients because the need for repetition of information is common and it's essential for appropriate management. Lastly, we need to think about providing education on the essential information the patient needs to know during that specific education session and not everything that would be nice to know, because very often, particularly for patients discharging from the hospital, they can very quickly become information overloaded. In fact, a recent survey showed that most anticoagulation clinicians deliver patient education in a single session that lasts more than 30 minutes on average. And most of these anticoagulation providers reported serious concerns of information overload in their patients. So to avoid this, education can and should be done longitudinally. Now, intuitively, patients will require the largest amount of education at the initiation of therapy, but this should focus on the fundamentals of safe and effective use of anticoagulants, the signs and symptoms of trouble, and when and who to call for help should trouble occur. We cannot realistically adequately cover all of the needed information in one initial session, so additional education and support should be layered in during follow-up appointment. For example, at follow-up visits, whether it's in person or via telehealth, these touch points can be used to address more longitudinal aspects of the patient's care to promote safety and efficacy. Things like wearing a medical alert bracelet, using adherence aids like pill boxes, encouraging patients to use their patient portal to connect with their provider, and their overall VTE management plan, including the anticipated duration of therapy. Other more nuanced or complex clinical situations relevant to anticoagulant therapy, such as planning or avoiding pregnancy or appropriate management around invasive procedures, can also be addressed at these follow-up touch points. Additionally, multidisciplinary clinicians should capitalize on all touch points within the continuum of care. And a really great example is refill pickups at community pharmacies, because these represent phenomenal opportunities for pharmacists to re-emphasize and reinforce key DOAC education and adherence points. So spreading comprehensive DOAC education out over multiple touch points will go a long way in alleviating the burden and stress on both patients and clinicians. Because there are so many education points, I suggest using a patient education checklist that's used by the healthcare staff when educating patients. And so at my hospital, we've developed an education checklist for each of the DOACs, and these are very helpful, particularly when we have learners or trainees participating in the patient education session, because they provide reminder prompts to ensure that no key points are missed. And we use what is known as a chunk and check approach, where the patient is provided with a short chunk of educational points, then their understanding of that information is checked using teach-back questions. And this process is continued until all educational points have been touched on and the patient or a family member or a caregiver has satisfactorily responded to the teach-back questions. If you don't have resources or bandwidth to build your own patient educational materials and tools, there are several outstanding patient advocacy organizations in the anticoagulation space that develop and share patient-facing materials that can be downloaded for free and adopted into your practice. If you are interested in developing your own materials, AHRQ provides a guide to help you assess the understandability and actionability of patient education materials, and you can access that for free on the AHRQ website. So I would encourage listeners and viewers to check out those valuable resources. We have several take-home points for this education session. So first, adherence is essential for optimal outcomes in patients with VTE. Patient-centered care approaches such as health literacy assessment and shared decision-making will set a really strong foundation for engagement and empowerment of VTE patients in their care. Use of multimodal approaches comprised of longitudinal patient-family education, increased touch points with patients, reminder aids, and use of electronic health platforms can promote DOAC adherence across the continuum of care. We hope this has been an informative session that will support you and your patients in optimized use of DOACs for VTE treatment. Thank you for tuning in.